Hi, I'm Dave Fernald, the editor of Diagnostic and Interventional Cardiology magazine, and I have with me Bridge Manny and Brian Bethay. They are the regional directors of the cardiovascular surgery and cardiology programs at Tenet Health Florida. And I want to talk to you a little bit about your structural heart program that you are both in charge of, and how you've actually put together your heart team, and what the heart team approach really means in structural heart.
Well, that's good. I think we're very fortunate. We're best friends. We spend probably about 90% of our days together, either on the phone or in person. But I think what that highlights more than anything else is that when you get the right heart team in place, the communication is constant, and it has to be constant for the patients to have the best outcomes possible, and then also for your program to be healthy. You know, we spend a lot of time talking both online and offline. We involve our entire team together, and we're always growing, but we kind of hold our mantra, I would say, is high performers but without egos that will work as a team. Those are the kind of people that we like to work with.
I think Brian just hit it on the head. We need to leave our egos behind outside the door when we come in. We are all very accomplished people in our own rights, and we were not trained to work the way we are working right now. So this is a learning experience, and for a site that's starting to do hybrid procedures, structural heart procedures, they really need to learn to work with each other, cross specialty lines. And it's not only the collaboration between CT surgery and cardiology, it's a true multi-specialty team, because you need your radiologists, you need your echocardiographers, you need your valve clinic people, and so on and so forth. And incidentally, even people like nephrology, because a lot of these patients have renal issues, so they need to be a part of the team. They need to see your vision. They need to understand what we are going to do to them and to their patients. Anesthesiology. So everybody becomes part of this big, happy family. And at the helm are the two guys, i.e. the surgeon and the interventionalist. And the other thing that I feel is very important is people need to understand the rigors of the other specialty.
Yes.
Interventionalists need to understand what are their issues. What is it that they can and cannot do? And one of the myths that interventionalists have, well, you know, something bad happened and I sent the patient to the operating room, and, you know, I washed my hands off this and all is well for me. Well, not really, right? And so they cannot fix everything, we cannot fix everything, but as a team together, you can decide what would be the best option, which usually is.
And you had mentioned too in a session, a breakfast session that you were talking in this morning, that even when you bring the echocardiographer in to take a look at something,
right,
you had mentioned the echocardiographer is usually looking at a sonogram that's a lot different. They're looking for something that's different than what you're looking for.
Yes.
So you need to be on the same page.
Yes, you need to be on the same page, and that's one of the reasons why I do my own transesophageal echocardiograms. And again, you know, as we were talking about in the morning session, is I'm not saying everybody needs to do that, but the idea is that if you have an echocardiographer who's imaging for you, they have to be in sync with you. They cannot be out of sync with you, because otherwise it's no longer a team effort. So they need to be doing the procedure with you rather than just being a surrogate that's just showing you a couple of images.
And with the advent of bundled payments coming down, some of the first ones are going into effect next summer, and likely more coming down for cardiology in the future. You had mentioned also that this heart team approach, you have it in structural heart, but when you have a patient that comes in with multiple comorbidities with AF, they have mitral problems, they have aortic problems, they have a left atrial appendage that needs to be closed. This kind of gives them an opportunity to have a one-stop shop.
Yes, it is, and that's the ultimate goal, right? The ultimate goal is to do everything that we do from a cardiac surgery standpoint, but with a catheter. And it leads to, if we can treat the entire spectrum of pathology that these patients present with, then it will only lead to better outcomes, lower costs, less readmissions, and that's where the bundled payment.
And I think I want to add to that is everybody's not a candidate. Just because somebody has aortic stenosis or MR or has AFib does not necessarily mean that we should be treating them. And that's one of the things that we have to learn collectively. This is a good patient population. This is a group of patients that we need to walk away from. And that can only happen if you're working with one another, learning from our past experiences, from CT surgical past experiences. And in the days gone by, people would say the eyeball test, and surgeons are very good at doing the eyeball test. Interventionalists were not as good at it because the surgeons have been burnt in the past when they took patients to the OR thinking they can fix everything and got burnt, so they learned. right?
Well, there's a lot of passing the buck.
Exactly.
Well, there is, and there's the old adage that a good surgeon is made because they have judgment, and judgment comes from experience, and experience comes from making bad decisions.
Yes.
And so that's where we are currently, but we're working with new technologies and difficult pathologies, and so it's nice to have a heart team when you have two people making that judgment instead of being out on an island by yourself.
And you had mentioned too in these procedures, if you're doing a TAVR, or you're doing any of these structural heart procedures, LAA closure, something like that you guys take turns. There's no superstar, there's no second co-pilot. You guys are
Actually, I think by interchanging like that, it not only helps you understand the device more, but also understands the patients better. I think it just leads to better outcomes. The more experience you have in all the different positions, the more well-rounded you are.
And one of the things that I feel very strongly about, we've all been in situations where things are not going so well, and we are all struggling. We're not getting the desired effect of what we initially planned out. It's a good idea when the other person is telling you maybe it's time to stop. It makes that decision process a lot easier versus you as the operator, you have to make that decision, I'm going to stop. And sometimes it's very difficult to do that because you're so deep into the procedure at this point in time, you're not thinking, take a deep breath, step back. Right. And that to me, working side by side, to me personally, is one of the biggest merits of a team that works with one another. Now you could also be on the other side where there is a team on paper, but they're really not working with one another. If you do not have that camaraderie, then that dialogue, walk away, dialogue does not happen then.
And with bundled payments coming, it's not really going to matter in the end who's on the team and saying what, because everything's you're going to be paid collaboratively.
Well, and moreover, more people are employed by hospitals or hospital systems, and so you're on a salary, which also frees you up then to function in a private practice, just like an academic setting, where you can just say no. This is not the right candidate because you're not worried about each patient being associated with your paycheck. And I think it frees you up to truly practice evidence-based medicine.
And you had mentioned in the session, which I really found interesting, is that you said when you started off that session 10 years ago, if you had said that I was going to be working with interventionalists, that would not be the case. I especially wouldn't be presenting at TCT at a 7:30 a.m. session. So today you said that you spent about 95% of your time with them.
Yes, and this is a big cultural shift for all of us, right? And I think a cultural shift for the better. Because I think we are taking care of much sicker people than we were 10 years ago. We are getting better outcomes. And if you look at some of the contemporary data, if you look at the CoreRAP 3-year data, some of the SAPIEN data, and some of the other data that are going to be coming out, that has only happened because people were willing to work with one another and do the right thing in an appropriate fashion in a controlled environment. This would not have happened if we were doing things our own way. The results may have been very different.
And this is the way of the future, you think, for cardiovascular medicine?
Yes, and I truly think, this is how we will be practicing, at least till we practice. At some point in time, the specialty may morph into one. Initially I used to get very excited about that one person doing it, like be a surgeon and an interventionalist at the same time, which I don't think is far-fetched. But the other half of me says, that may not be such a good idea. And the reason for that is now you've supplanted two people with one person. And that's where the merits really are, two people working on one person, which will be lost.
I completely agree, and I'll add to that. There's no doubt in my mind that one person could do these procedures from a technical standpoint. But as I talk to the patients in the clinic, I say you get the best of both worlds. You're getting a 2 for 1. And who doesn't like a good value meal, right?
And to your point also, both of your points, we're at TCT. They have an entire track now for cardiovascular surgeons, and you're here presenting on a regular basis.
Yes, this is, in the days gone by, surgeons were a rarity at TCT. It was an interventionalist show. And there was no reason for a surgeon to come to do what, right? So now this is as much of a surgical meeting as it is an interventional meeting, to be truly honest, right?
Yeah, I've really seen that merge on the last few years.
And it's not only from a structural heart perspective, it's from a coronary perspective as well. High-risk PCI, doing chronic total occlusions, doing hybrid revascularization, a heart team approach to discuss high-risk cases. We all sit down in a room together and say, okay, these are the difficult cases. which one is better, surgery or high-risk PCI, and let the chips fall where they may for the best outcome for the patient, because that's the most important. At the end of the day, if we do it all well, we'll have plenty of business for both sides. But we cannot say, I'm going to hold my patients right close to my chest and not share them, because I think that's where we've gone wrong in the past. And by sharing our patients and providing them the technology that fits the patient, not the operator, is the holy grail.
Thank you very much for your time.
Thank you.
No, thank you.
Appreciate it.